Medical home is, I hope, our way to really salvage primary care.
A place where people can come for all their medical care. They don't have to worry that, you know, we've got half of what they need, but they're going to have to go elsewhere to get anything else done.
It's a place that coordinates all of your care.
A place that knows about you and knows about your individuality and keeps track of what's happened with your health over the years in a way that it can be presented back to you in a concise and understandable way so that you can make the best possible healthcare decisions.
My name is Eleanor Cochran. I'm an RN healthcare coordinator here at Dartmouth-Hitchcock. The role itself is not clearly defined. This is a complete work in progress, and we're breaking ground in a lot of different fronts. So we're trying to find the best way to use the skills we have and also to enlist other team members to use the skills they have so that patients are benefiting from a much broader skill set.
Before we had this model set up, it was very frustrating because there were sort of a constant list of about 10 to 20 patients that I knew needed more, and I knew I couldn't do what needed to be done for them. I sort of view it as a very nice safety net for me and for my patients. You know, when I know that when I can't get something done, I have someone who can work on it for hours if need be and keep on hounding on it until it happens.
I think one of the shortcomings of healthcare in this country has been that we have not paid attention to the patient.
I have a very complicated medical situation, and when I was in Maryland, I was going from doctor to doctor, and I would have to carry all my records with me and start from square one with each doctor. But since coming to see Dr. Cashaw, he was able to pull everything all together for me. Well, the benefit is all the doctors talk to each other. They all know my medical care. They all centralize with Dr. Cashaw, and I just have to come see him and find out the best diagnosis and what to do for me.
I feel like they keep track of everything that's going on with me medically. When I see the physician, he has a more holistic view of me than I would think other general practitioners would have.
One patient at a time, I think, is our mantra. The patient who's on the phone, the patient who's in the hospital, the patient who's in the lobby, the patient who's sitting in the office. That's the patient who gets the attention at that point.
I was depressed for about 8 months, severely depressed, and I called Eleanor because I had become friendly with her through Dr. Cashaw, and she was the one that I confided in during that depression. And she called me at home and gave me her home phone number and was the one that really helped me. And then Dr. Cashaw referred me to Dr. Tom Stearns, and between the three of them, I'm a different person.
I'm located here, and that really makes a difference versus, you know, being referred to private practice across town or community mental health center and stuff like that. So, you know, Eleanor, the care coordinator, we can catch in the hallway and say, geez, I just talked to Carol. What do you think I ought to be talking to her about? I know she's kind of depressed. So, you know, being right where we can share ideas or catch Dr. Cashaw and say, geez, here's some thoughts about what you might do, or for him to literally be able to walk down and sit down and ask me something. That's really one of the real luxuries of having somebody on the team, you know, right here.
I have many patients that are depressed, and you take someone who's depressed and tell them they need to call the psychiatrist and set up an appointment and get themselves set up with a counselor, and here's the number and bye. And it doesn't work. I mean, if you're already uninspired about doing things and wake up and you feel like you want to die, it's a little difficult to, you know, follow through with a bunch of phone numbers that you're given to call someone you don't know. You know, Eleanor seems to just work hand in hand with Tom. I mean, she's gotten many of my patients set up with Tom, and he can spend an hour just talking about options, talking about coping mechanisms, talking about facilities we have in the community that can help, whether it's getting set up with a long-term counselor or a psychiatrist, or assistance with medications, or just talking through, you know, what to do in the middle of the night when you can't sleep and you're worried about something.
Relationship is the key for all of us, and for medical home. It's about touches with patients, whether they're short, long, acute, or just ongoing. And in the case of Carol, that was a relationship that started on the phone when I was a triage nurse. And trust is built when we work together. And when a patient trusts a provider, other members of the team, from the receptionist to people in the community, specialists here, then we can really do something that's therapeutic.
So the Medical Home Project now is a way to reinvigorate that old-fashioned family practice home where you get 90% of your health care, and use that to then take all the complicated data that's generated at this office and other offices, other hospitals, diagnostic facilities, and bring that data all together in a meaningful way, and be able to summarize that back to the patient or to consultants or to hospitals or whoever else needs to know that thumbprint of that patient.
When I was diagnosed with diabetes, I got referred immediately to the nutritionist and to the certified diabetes educator within a couple of weeks. Lamprey tracks what I do. I get an A1C right now every 6 months because I'm in such good control. And when I see Dr. Friedrichs, you know, he pulls out the chart and he looks at that, and we analyze what's going on. And my A1C at the last time was 5.6, which is 4 to 6 is normal. So, you know, for somebody with diabetes for 11 years, that's pretty good.
An incident happened that completely changed our lives. I was injured very badly, accosted by 5 teenagers that beat me up to the point of, you know, broken vertebrae and all my teeth knocked out. My nose was over here someplace, and it was in front of my son. So other than the physical aspect of that, you know, it had some, I was worried about the ramifications it would have on my son later on after, you know, seeing his dad be, you know, beaten. That happened 5 years ago. So I was in a really bad place. Still injured. The problem wasn't solved physically at all. Not to mention, I lost my business, my house, my car. I mean, everything that we ever had literally went because I couldn't work. And then I met Dr. Kasha, and he took it from the beginning, like by priority. You know, let's start at what needs to be, you know, addressed right now, and we'll take it step by step. Everything from dentists to ears, eyes, and nose doctors to behavior specialists.
To help James heal, he needed a whole lot of pieces. He needed help from the community. He needed help getting his medication. He needed help to get food from the community kitchen, and clothes from the Goodwill, and a bed for his kid, and some self-esteem back, and a ride to Hanover, and just a whole lot of things. And no, those don't look like traditional health care. It's not a pill and it's not a procedure.
I didn't have any money, I didn't have any food. Philip and I were sleeping on the floor in sleeping bags. You know, I mean, zero, nothing. I didn't know anything about welfare or agencies or food kitchens or anything at all. They pointed it out to me.
When the patient is in the center, it takes a whole lot of effort, but the results are much better. And I think James is a perfect case in point. He's a functioning, dignified human being today, and he's in charge of his own fate. Even though I bug him about getting his labs done, he makes the decision about whether to get there.
Eleanor's been great on that. You know, she has the time to call him and sometimes hound him, but most of the time just call him and encourage him about what he needs to do.
I was completely overwhelmed that anybody would take that much time to care about a patient. It's an unbelievable experience, you know. I wouldn't have been able to do anything I'm doing now or progress to any degree without them. I would just apply for a disability and figure that was it for the rest of my life, you know.
When we share stories like Carol and James and other patients of ours, I always am quick to say that these are not unique, they're not aberrations. These are happening every day. There are 7 of us in place, and we all have stories every single day. And many of them are on a par with Carol and James' stories. Some of them are even more profound.
I'm starting to deliver babies of women who I delivered as babies 20 or more years ago. The reason I'm tearing up is because one of those babies died of a SIDS death a little bit after he was born. But you know, I was so invested in that family and knowing them all those years. That's where the payback is to me, is the continuity of care. So I'm working real hard to keep that going and not give up hospital practice, even though the trend in this area is to give it up. Because if I get to know somebody and start incorporating my knowledge of their values in their healthcare decision, I like to be there when they apply those values. So I like that individuation, I like that continuity. So it's really paying off for me at this stage of my life because of having many patients 5, 10, 15, 20 years or more.
One of the providers on the team who was trying to explain medical home to the rest of the team so they could be part of it, he finished his presentation and under his breath he said, "That's the care I want." And that's how I feel. That's the care I want for myself, for my family, and for my patients. And I think we all feel that way, that that's the standard of care that we should be able to expect.